Assalamu alaikum, this is Shama and today we're going to discuss a very important topic of the gastrointestinal tract, that is ulcerative colitis. So yes, all the persons who are watching it, if they're studying it for the pathology purpose, they can even go through this video, and if they're looking for the medicine part of the ulcerative colitis, they can also see the video. So before we start the video, it's a humble request for everyone who is watching that please just press the subscribe button under my video. It will help me a lot, and thanks a lot. So just starting the video, it's ulcerative colitis. So from the name, in this video we'll discuss the clinical features of the disease, that how the patient of ulcerative colitis presents, then how we'll investigate that patient, plus at the end we'll discuss that how we will manage the patient of ulcerative colitis. So starting with the disease, what does just listening or the name of ulcerative colitis comes in our mind, that first, okay, that there may be some ulcers in this disease, and by this itis there will be some inflammation in this disease, and where probably it's colon, so intestine may be involved. So these are the three things which will come in our mind. Okay, now moving on, that what happens in this disease, combining these two points which we have understood. So it is basically an inflammatory disorder that actually involves the rectum, and then this is the rectum, and it then extend to the sigmoid colon, and then the descending colon and transverse and so on to the proximal colon, and ultimately the whole colon will be involved in case of severe disease. So what happens is that in it, mucosa will be involved. Mucosa will be hyperemic, fragile, it will bleed on touching, and there will be inflammatory exudate, inflammatory cells infiltrating within it and in the crypt, so it will lead to crypt abscess formation. So this is the whole overview of the pathology that will occur in this disease. Moving on, that okay, now the main difference between the ulcerative colitis and the Crohn disease is that in Crohn disease, the disease then it extends in the form of skip lesions, that a part of the intestine will be involved but a part will not be involved, while in case of ulcerative colitis, it is that it extends from the rectum in a continuous fashion, like the whole intestine will be involved continuously. So that is the main feature of ulcerative colitis, differentiating it from the Crohn disease. Okay, now continuing it, that how will a patient present to us with ulcerative colitis? There are three major criteria on which we decide the clinical features. That first of all, which site of the intestine is involved, what is the extent of the disease, and what is the severity of disease. Okay, now talking about the site, that okay, first of all, if just the rectum is involved, we call it that proctitis. Patient is having just the proctitis, means inflammation of the rectum. So if it does extend forward up to this sigmoid colon and then this descending colon up to this flexure that we call the splenic flexure, so it will be the left sided colitis. Why? Because only the left side of the intestine is involved. And thirdly, when it becomes severe, that it involves beyond the splenic flexure, then it will be pancolitis, that it involves total colon plus the rectum. So these are the three site and extent context of the presentation of the patient. Fine. Moving on to the severity. Now the severity is important, that it is either mild, moderate, severe or fulminant. So mild is, just remember 2-3 points in your mind, that first of all, extent of stools the patient is passing, like number of stools, then is there bleeding present, if present then what is the degree of the bleeding, and thirdly, that if the patient is having signs of toxicity. Okay, talking about the mild disease, if the patient is having less than 4 stools, like passing less than 4 stools a day with or without blood, fine, and there are no signs of toxicity in the patient, then it is a mild disease. Okay, moving on to moderate, if the patient is passing more than 4 stools a day with blood, and like you can say that few signs of toxicity are present, there is fever or tachycardia, and these signs are present, abdominal pain, and these are the signs, anemia present in the patient, but in mild degree. This is moderate. Talking about severe, in severe is that patient will be passing more than 6 stools daily with blood, and signs of toxicity will be now more severe. And in fulminant stage, he will be passing more than 10 stool, continuous bleeding, patient will be having severe anemia, and patient will require immediate transfusions will be required, and yes, now complications will develop in it, that is the toxic megacolon will be present. In that case, that colon will be dilated. So this is how the patient will present to us, and how will identify by the symptoms and signs seen in the patient. Now talking about that, what investigations will we do in that patient, we'll talk now. Okay, now talking about investigations, it's that first of all, now just an easy way to remember the investigations, that we know bleeding is occurring in the disease, so first remember blood. Okay, secondly, that we'll of course do the radiological investigations, and these investigations will be to, like, we have to visualize that what is the inside of the colon and the rectum, to see that. And thirdly, investigations we'll do to just to rule out that whether any infective cause of ulcerative colitis is present or not. Okay, so talking about the blood, in blood we'll go for CBC, and what we'll see in CBC, patient will be anemic. Second, we'll go for ESR. Now, since inflammation is present, ESR and CRP, now they will be raised, and they are raised in either the severe disease or the fulminant disease. Third is severe disease or fulminant disease. Sorry. So the third investigation in the blood is that whenever bleeding will occur, what will happen is that albumin will also start to lose from the blood. So we'll go for serum albumin levels. Okay, now serum albumin levels, if they are less than 3 gram per liter, then it is evident that ulcerative colitis is present. Now these are the three investigations in this cases. Then in radiologically, now first of all we go for plain abdominal radiograph. Now in the plain abdominal radiograph, we'll see first of all that the colon inside, what is the diameter of the colon. Now if the diameter of colon will be more than 6 centimeter, then we'll say that toxic megacolon is present in that disease. Okay, or we'll see that gas under diaphragm. So this is our diaphragm and these are our lungs, we know. So if some gas, means blackening, is seen under the diaphragm, then that will be evident that okay, some perforation is present in the patient. Okay, that is a complication particularly, and this toxic megacolon is also an acute complication. Talking about this is plain abdominal radiograph. Then now to visualize is, first of all we'll do sigmoidoscopy, and then we'll go for colonoscopy. Now before these we'll perform barium enema. Now this barium enema is that we'll pass the barium material through the rectum, and we'll see the inside of the rectum and colon. Now the evidence will be that if there is loss of hostrations or pseudopolyposis will be present, plus because of the disease advancement, ulcerations and nodularity, they will be seen in the disease, which are evident of ulcerative colitis. Okay, now if after barium enema we are not sure about the diagnosis, then we'll go for sigmoidoscopy. By a scope we'll look inside the sigmoid colon, and yes, of the suspicious areas we'll go for biopsy. Now biopsy is done both with sigmoidoscopy as well as with colonoscopy, and then we'll go for colonoscopy. Now in it we'll visualize the inside of the colon. Now evident colonoscopy, what evidences will we see? That first of all, if we can differentiate ulcerative colitis from Crohn's disease. Second important point from colonoscopy is that we can see, now I have already explained you, the disease extend proximally. Now by colonoscopy we see the proximal extent of the disease, and third important, we can see with biopsy that whether there is any cancerous development, that is a chronic complication of ulcerative colitis. So these are the investigation. Now third, I told you before that to rule out the infective cause. Now for infective cause, what we'll do is we'll take stools of the patient and we'll send it for examination. Now we'll go for stool examination. Why we go for it? Why? Because to rule out the infective causes. Now what are those infections that can occur? So I have made a mnemonic for it: SAC. Okay, S is Shigella, A amoebiasis, and these three C are cytomegalovirus, Campylobacter, and third is Clostridium difficile. Now, if patient is having Clostridium difficile, then there can be a point that it occurs more commonly if the patient is on antibiotics. Okay, and if cytomegalovirus, then this virus is more common if the patient is immunocompromised. Okay, now talking further, these are the whole overview of how we will investigate the patient is management of ulcerative colitis. Now, we've already discussed that since ulcerative colitis is an inflammatory disease, okay, now what measurements we'll give, that we'll go for anti-inflammatory agents, of course. What are the anti-inflammatory agents? We have two options, 5-aminosalicylates that are mesalazine or sulfasalazine, or the prostaglandin inhibitors. A step forward, if patient doesn't respond to these anti-inflammatory agents, we'll go for steroids that we know they are an anti-inflammatory agents. And further, if the patient is not responding to both of them, then we have an option of immunosuppressant. Now, why immunosuppressant? That since patient is having an inflammatory response, so our last option will be that first we have done to stop we have given anti-inflammatory agents to stop the inflammation. Then we have given a step further, steroids. Now, what we'll do is that we will actually suppress that immunity that is actually producing that inflammatory response. So we'll give immunosuppressant to that patient. We have options azathioprine, cyclosporin, or anti-TNF agents. Moving on, that now these are the options of medications we have, and further we'll go for surgery that I'll discuss in the last section of this video. So yes, since we have discussed before in the clinical features that we have mild, moderate, severe, and fulminant presentation of the patient, so of course we will manage the patient according to the problem he is having now. So first of all, if the patient is having mild disease, then we'll start with the very lowest step, that is the baseline step of the disease, that that we'll start with the topical agents, then to oral, and then to IV. Okay, so in mild or moderate disease, what we'll go is that we'll start with topical mesalazine. So this I've just written its abbreviation, topical mesalazine. Okay, now if the patient is not responding to the topical mesalazine, we'll go for topical mesalazine plus we'll add now oral sulfasalazine in the regime. And if the patient respond to it, well and good. But if the patient is not responding to it, then or because if he is resistant to aminosalicylates, then we'll go to oral steroids, the second step of our therapy. We have options prednisolone, budesonide, or betamethasone in that case. Moving on, that yes, now if the patient has responded to them, now we'll give maintenance therapy to maintain the treatment we have given. So for that we go for, again to the start, mesalazine, but now one daily oral mesalazine will be given to the patient as maintenance therapy. Moving on, that yes, this was, we talked about the mild to moderate disease. Now we'll talk about severe disease. That in severe disease, if the patient, now we'll start with the second step and add the first two. We'll give oral steroids to the patient plus high dose aminosalicylates oral plus topical aminosalicylates to the patient. If the patient respond to them, good. But if the patient is not responding to this regimen, then what we'll do is a more step higher. We will now admit that patient and give IV fluids. This F is like IV fluids and IV electrolytes to the patient, and IV steroids, IV hydrocortisone is given to the patient. Now we know that we can't continue the IV medications for a long time. So once the patient is responding to IV medication, what we'll do is that now we'll give the same dose of oral hydrocortisone, and then we'll gradually taper it down, and then we'll discontinue the steroids. Okay, moving on, this is the therapy that we give in case of severe disease. Now moving on, that if the patient is having, now he is having many relapses of disease, like more than 2 relapses of disease in 1 year, and we have to give steroids in that case. Or secondly, if the patient is having steroid dependent disease, okay, in these cases, now these are the indications, what we'll do is that we will go for a step higher, immunosuppressive agents in that case. Then what we'll do is that we'll give cyclosporin. We discussed before that cyclosporin will be given, or azathioprine, or we go for anti-TNF agents in that case. Okay, now further moving on, this was the treatment for the severe disease. Further moving on, that now how we will treat a patient who is having fulminant disease. Now discussed before, in fulminant complications will develop in the patient. Okay, now in fulminant what will go is that immediate, now we'll take aggressive measures, that we'll immediately admit the patient, plus we'll closely monitor the patient, we'll make the patient NPO, nothing per oral, and we'll start the medications. What? We'll give IV steroids to the patient. Okay, now if the plus we'll of course give IV fluids and IV electrolytes. Now if the patient is responding to them, good, but if the patient doesn't respond to this therapy, then we'll move a step further. What will go, that we'll go for cyclosporin given to the patient, or infliximab, immunosuppressive agents we'll give to the patient. Now third step, that if the patient is not responding to the to this medication, or if the patient to these medications, if the patient is not responding for more than 3 days, then we'll go for this regimen. Then if the patient is not responding to these medication, we'll go to for 7 to 10 days. Then what we'll go is that we'll go for emergency colectomy, that is resection of the colon. That will be our surgical management will prefer. When? If the patient is not responding to cyclosporin or infliximab for more than 7 to 10 days, or if the patient has developed complication, that is toxic megacolon, we have discussed before. If the patient has developed that and that is not responding to medication for more than 72 hours or 3 days, then we go for colectomy. Okay, so this is the whole medical. What is the surgical management of ulcerative colitis? What are the indications of surgery? A very good mnemonic, how we can memorize it very easily and very quickly. And yes, this is the whole essence of the today's video. So yes, what is the surgical option? That is reconstructive proctocolectomy. Now what is that? It is, we by this name is that now we'll reconstruct something. We'll remove the procto, means rectum, or colec, that is colon. We remove this and we'll reconstruct a whole path for defecation purpose. Okay, now talking about that, what we'll do in this procedure is that we will resect the rectum mucosa, we'll resect the whole colon that is involved, and we will preserve the anal canal. And what we'll do is that we will combine now this iliac pouch, it will be reconstructed and attached to the upper anal canal, so that a new passage of defecation from ileum up to the anus is made. So this is the whole procedure briefly. Now in any patient, if we can't perform this procedure, now there will be an alternate for that procedure, that is Koch continent ileostomy. So this is one procedure. If not, we go for Koch continent ileostomy. We will make a ileostoma in this procedure. Okay, now moving on, that important point to discuss now is that what will be the indications, like when to perform this surgery, why not to prefer medical management, and when to just do it. So for that we have divided into two major parts. First is emergency colectomy or the elective colectomy. Okay, so for the emergency colectomy, what are the indications? Easy mnemonic for that to memorize is, just imagine when we will go for an emergency. When, first of all, just remember, if medical management, there is some issue with the medical management, or patient has developed acute complications of the disease. So medical management problem, what can be the problem with the medical management? That patient is symptomatic and he is not responding to the medical management, then we'll go for emergency colectomy. And what stage? If patient is at severe fulminant stage and he is not responding to the medical management, then we will prefer giving surgical emergency colectomy in that case. Secondly, if acute complications of the medical management has developed in that patient. So two indications are done. Moving on to acute complications of the ulcerative colitis. What are they? We have three acute complications. First of all, if the patient has developed toxic megacolon, that is an indication of emergency colectomy. Moving on, if the patient has developed perforation. And third is life-threatening hemorrhage. These are the 5 indications of emergency colectomy. An easy way to memorize. Problem with medical, acute complications. In elective phase, the mnemonic to memorize is that first of all, remember this, the same procedure we discussed before. Medical. What will be the problem with the medical thing? First of all, patient, now we have given medications to a patient. First thing we see is that whether he is responding or not. So first is if the patient is not responding to the medical management. Second, we have given medical management, he responds, but once we discontinue, there will be relapses of the disease. So no response, relapses are present in the disease. And third indication is that patient has developed complications for the disease, for the medical management, sorry. So these are the 3 indications related to the medical. Second important point you have to remember is that to avoid risk. Now, what are the risks? We avoid risk of long-term immunosuppression. We avoid the risk of long-term immunosuppression and in malignancy development. So these risks to be avoided. And third important the point of elective indication is that chronic. Now in emergency we'll discuss acute complications. In it we'll look for chronic complications. Now what are the chronic complications? Chronic complications are that if the patient has developed cancer. Now cancer, if the patient has developed cancer, then we go for elective colectomy, or he has been diagnosed with dysplasia. If he has developed cancer, onset of cancer, or if dysplasia is seen on the biopsy, then we'll go for elective colectomy. And second complication is extraintestinal manifestation. So in that case, to manage these extraintestinal manifestations, we go for elective colectomy in the patient. So thank you very much. This was the whole video of ulcerative colitis. I have tried to make it so easy and concise that within just 15 to 20 minutes, you can easily memorize the whole topic of ulcerative colitis. So at the end, please give a like, share and comment at the videos if you like them. Thank you very much. I'll see you in the next video. Allah Hafiz.